let's go ahead and move on to our regular meeting. Thank you, guys. Do you have anybody else? Other public that wants to come in?
Yeah, there's a couple.
Oh, there is a bunch of people.
6 or 8.
Okay.
All of you sign in, please. Keep on coming around so you can sign in.
Go ahead. Monty. I don't want to take your seat. Okay. I'll just.
We've got just a little bit of business to do, and we'll get some public comment. I'm going to go ahead and open the meeting. Are you ready, Ian? Yeah. I call this February 27, 2014 board meeting of the San Juan Health District to order. We're going to look at board minutes from January 16th. We ask everybody to turn your cell phone on for silence. Doesn't interrupt our recording. Anybody have anything on the minutes?
Make a motion.
Burton has a motion on the floor. Motion by Burton and second by Gale to approve the January 16, 2014 minutes. Any further discussion? All those in favor? Opposed?
Since I wasn't in the team.
Okay. So we have 3-4 on extension. Let's move on to the work meeting minutes, February 13th, 2014.
I didn't see anything that needed to be changed, so I will make a motion that we approve them.
Motion by Steve, seconded by Burton to approve the February 13, 2014 minutes. Any further discussion? All those in favor? Motion's carried. Okay, we'll go into public comment. I want to say a few things before we go into this. Thanks everybody for coming. We usually do not have this big of a crowd, so it's nice to see people are interested. And if you haven't been here before, I kind of need to let you know how our meetings are ran. This isn't really a question and answer period. We're here to work. So we have a lot of business to do tonight, and this is our time to be presented with facts that we can make decisions on according to our agendas. So our board meetings can run late, so we try to move them along as quickly as possible. That being said, we do abide by the open meeting laws of the state of Utah. Our sessions are open to the public unless it's closed, and we will vote that way, close the session. But the entire meeting is not open for public comment. We will have a public comment time now, because we do like to hear the community concerns and praises for what we do. So we've allowed a short time for public comment tonight. I'd encourage you to keep your comments short, productive, and to the point. And then we'll close the public comment period. And then from there on, the rest of the meeting, we will not allow any public comment. I'd like to limit you to 5 minutes apiece, and maybe 35, 40 minutes of public comment if we have that much. If we have some extra time, maybe if you didn't get said what you want to say, maybe another little bit. Some things we can comment on, and some things we cannot comment on. We cannot comment on any personnel issues that are internal that may affect the personnel record. We cannot release any information about that. I don't think we should comment on any currently or formerly employed personnel. We do not comment on anything that's been discussed in a closed session of the board. We will not comment on anything that we've been advised by an attorney not to comment. Things we can talk about are finances, our financial situation, comments relating to the services we offer the board, our role as a board, organization as a whole. I do not want any public attacks on any members of the board or our staff. I want to state that now. If I feel the comment's heading that way, I'll ask you to please end your comment at that point. So if you raise your hand, I'll call on you. I'll open public comment now. Please state your name. Step up where we can hear you. We'll go from there.
Excuse me, you just told us we can't say anything pretty much. So what, who's going to stand up?
Well, we're bound to not release
Whatever.
anything that we discussed in the closed session. You're
No,
welcome to
no, you
ask
just told us we
questions.
can't say, address.
I don't think that
No,
that's what he said at all. And if you have a comment, you may as well go ahead and comment. And if we can't discuss it, then we simply won't.
Sure.
Somebody should probably go first because, and maybe I'll say something in a minute.
Looks like you're up.
I'm up. Oh dear. I do have a question on a report that was received,
Yeah.
Bonnie DeRozier, Monticello. Regarding the operating of the hospital, how it could be rectified. And I don't know whether you can comment on it or not. Can we get any specifics on that?
Can you be more specific about what you mean?
I don't know the company you employed to make the recent study on the hospital.
We didn't employ.
It was a report that would have been received recently.
Actually, we're gonna review that
Okay.
later tonight, and we have not had a chance to do that as a body.
Okay,
We've been given it as homework, but not
okay.
discussed.
Yeah, and you may be referring to a report that Cerner, which is the provider of our medical records, our electronic medical records system, did for us relative to billing.
Because, you know, I'm sorry, I left half of my notes at home, and that's bad. I usually come very prepared when I do come to one of these meetings. But Burton, if you say that you're probably addressing it later on, I will wait for that, but then we're not allowed to say anything then, so.
Well, it's just not conducted to the.
Exactly,
meeting.
I understand that.
Sorry, it's,
I understand.
Yeah.
But I have talked to, one thing that does.
We're not antagonistic, so you can actually.
Well, I
relax.
can be, so that's why I debated. But I was faced with this quite a few years ago when I was an employee for the hospital. So I know what can go on. And I know what happens to employees who, even when they have proof, because I worked in medical records, when you go against the established hierarchy of San Juan County Hospital, you lose your job. And so people that I have talked to, not necessarily employees, though some of them are, they won't say anything because they're afraid they're going to lose their jobs, but they're also afraid they're going to show up one day and there's not going to be a job because this is a quickly sinking ship.
Well, I would say that that's something that we are, that we're failing mightily, and we don't think it will sink. We think we can salvage it. Certainly we have many problems. I personally wouldn't care to talk about what's happened in the past. Relative
No,
to
but I'm
personnel
just,
issues.
I understand that. And that the only reason I brought it up is because I've been there and I know what happens and why people won't talk.
Well,
That's the only reason I brought it up.
Well, I've had one employee be very open with me this week.
That's good.
They're still employed.
Well, I hope they still will be, but everybody that I talked to said, please do not mention my name. So,
Well,
okay.
and
Oh,
there's several people in this room that have come to me privately.
Okay.
And, you know, I appreciate it. I listen. Sometimes it's kind of like Garfield and that cartoon, you know, where somebody's going from his tail to his head and it rubs me the wrong way. But I like to listen to people and I tell them that. A lot of people say, don't reveal who I am or don't
Right.
quote me on this. And I try to protect that.
Yeah, well, that's what I'm doing. But-
Because if for one thing, if you burn them, then they won't talk to you the next time.
Ever again.
Yeah.
Exactly.
So,
And I can appreciate that, and that's exactly why I'm not naming any names, because I promised them I wouldn't. But it's, like I said, employees now, and former employees, patients, and you already said no patient care, so I'll leave that out. But we're not going to have a hospital. We already are down 3 doctors. What doctor in their right mind is going to ever come here now? I don't care how quickly their student loans get paid off. There's plenty of other smaller hospitals that they can go to.
Man, you're speculating, and if you'll let us do our jobs, we may very well find doctors to replace the ones that we are losing.
You need to protect the doctors we already have.
The doctors
That's
that
what you
we
need
have
to
have
do.
chosen to leave for whatever the reason, and that's their choice. That's not our choice.
I'm going to interject there and say that largely what she's talking about is one of the reasons I'm leaving.
well, and like I said, this isn't gonna be a debate because we've been accused of debating public comment before in the press. And people should be feel free to express your opinion. We feel like we want to defend ourselves, but you know what? That's not the position here that we should take. You should, you know, right? And I think your time's up too.
If I'm going to be the only one talking, though, I get 35
Well, I
minutes,
guess-
right?
No, you get 5
That's right,
minutes.
yeah.
Yes, Isabel Ray Monticello, are you members of the board actually going to acknowledge that there is a personnel problem at the hospital? Are you going to take the bull by the horns and remark that there are all sorts of problems that have been there for a very long time? We've actually come to this point where you're losing 3 doctors. Are you going to do anything about it? Are you going to change things so that you might be able to entice some doctors here? And maybe they'll last for a year, maybe they'll last for 2. But then the same thing that's happened over and over again is going to happen again. You'll be saying, why are we losing our doctors? Why can't we keep them? Are you going to investigate this properly or not? That's my question, that's my comment.
Well, as far as I'm concerned, the answer to your question is yes, we are addressing the issues. The issues are fairly large and fairly complex. And I suspect it will take some time to get to the root of them, but we are hoping to clear the air and have and start with a new slate.
I have a comment. I'm Diane Black from Monticello. I want to thank the board. You guys have been putting in long hours and lots of worry and stress. You've talked to many people. I don't know all the problems, but I know that you guys are aware of them and you're doing your best to take care of them. You've been bashed and criticized publicly. I want to say thank you publicly because I feel like you guys are working hard. Like he says, it's deep and you're working on it. You're working on fixing things. I'm sorry we're losing Dr. A. I think he's a great doctor, but I think the board is working to remedy the problem. And for the most part, they don't get paid very much to do what they're doing, and they have been through hell and back. So, thank you.
I'd like to make a comment if I could. What?
Tell us who.
Oh,
I know.
oh, come on.
For the record.
For the record, this is Donna Seeger. And I do represent both Blue Mountain and UNHS. I have stepped down as the CEO, just to let you all know that, if you all do know that. But I am still on contract with them for consultation and representation. And I am a board member with Blue Mountain Hospital, so you understand the background. But I just want you to know that I worked with San Juan Hospital for 18 years. And it's my hospital too. Just so you all know that's how I feel. And I just want you to know that Utah Navajo Health System and Blue Mountain Hospital are more than willing to work together in whatever capacity we can to provide a countywide healthcare system. And we need to learn from the past and move forward with what we've learned. And we need to do it cooperatively and collaboratively. San Juan County starts with Moab and it ends with Arizona border. And if we can expand our vision to look at San Juan County in that way, there's no reason that we can't have high quality health care everywhere. And I just want you to know that was my instructions to represent that to the board and let you know that that's the way we feel. That's the way we're willing to work. And there are some positive ideas that are sprouting among conversations that could certainly be a source of ideas for actions and things that we can do to help the whole county have better health care. Thank you.
Don, I have a couple questions if you don't mind. Who asked you?
UNHS and Blue Mountain Hospital. Jeremy and Mike. Jeremy's out of town. The rest of my admin team had funerals today at North. And Mike may stop in just a little while, but I know that your period is short.
Well,
our children in baseball games.
I understand. I only ask because this has been a passion of mine for quite some time. And I'd like to know that everybody is for the community because I think it's critical to our overall success.
I just know I can speak for the administration teams. I've been in the board meetings. They're a little hesitant to see just exactly what's going to happen here. They certainly are supportive with the idea that we have, that we work together. Because there's ways that you can save Blue Mountain Hospital money. There's ways that we can save you money. Why not work together?
We'll take back the message that we will work very hard to sort out the issues and make this successful.
Okay.
Actually, we've been committed to critical access hospitals in the county for a long time and felt that the county's never been better served. And, really quite wanted to foster that, continue that, and work together to keep people at home so when they need these services, they can stay.
They can get them here.
you know, the $8 to $9 million in Medicaid money alone that bleeds out of the county, the last study we had, can be captured.
Exactly.
That right here.
Exactly.
Work together
And that's the way we need to be doing this. We need to be looking at data. We need to be making data-driven decisions for the county. And I think if we'll move to data-driven decision-making, needs analysis, that kind of thing, I think we can move forward. And that's what we're committed to. And just like you said, which is the perfect response, because with UNHS, what we've done is we've taken healthcare to the people and captured the funds that were going to Shiprock and other places and brought them into San Juan County. And if we can all just realize that that's the way we need to look at things moving forward, we can be successful.
Well, and Donna, as I'm sure you're aware, it's not only a matter of capturing the revenue that's bleeding into this hemorrhage from San Juan County, but it's also saving money in terms of expenses, cost sharing, and that sort of thing. So if we work together, we can actually have many, many benefits.
And one last comment from a CEO perspective. I want you all to know that we started with Blue Mountain Hospital with electronic medical records. So we've had time. We actually changed our system because there are many systems out there. But we chose one. There are no perfect systems. You need to know that. There are no perfect systems. And the transition is extremely difficult for every employee in the hospital. The providers significantly, and initially that's the big challenge, and then all of the support staff, because a full electronic record means everybody has to be involved. And it's very difficult. You have to change your thought processes. It takes time. With Blue Mountain Hospital, when UNHS took over and assumed management of that hospital, we took the expense of doing a different system. It's not Cerner. Cerner is one of the top lines, no question about it. And it is one of the more expensive ones. It's also good. It's not perfect. There are no perfect systems. And I know that your CEO, acting CEO can tell you that. So you have to, as a board, understand that it's not an overnight transition. It's difficult for every person in the hospital. So you have to be patient. The cost is significant. The ongoing cost of maintenance is significant. And you know, you may decide to stay with Cerner and continue that monthly cost, or you may want to look at a different system. But the point is, you're going to have to be patient because it's expensive, but in the end, it elevates your quality of care 150% across the board. And everybody knows more about what's going on, and you can make data-driven decisions. So I just wanted to share that experience from that level. Thank you.
Alan,
Yes.
may I ask a few questions? I know the talk's over. May I ask a few questions?
If you want,
Of Donna.
yeah.
Donna, you mentioned that you actually changed systems, and it's something that we've discussed, although we, as you know, are in this system well over $1 million. We have no sense of how we might do away with Cerner and replace it with another system. And to me, that seems illogical. Seems more sensible to work with what we have. There have been some successes with Cerner of late, so I guess I'm confounded by how you may have just let go of a very expensive system, or how you afforded to let go of a very expensive system. And did you find it worthwhile?
Yes, we found it worthwhile, and one of the reasons is because the system that the initial CEO of Blue Mountain Hospital had, and that board had approved, was not nearly this expensive. This is a huge investment, and it's a huge investment of county dollars. So one of the things that I would suggest is that you contact another small hospital that's using the Cerner system, and I think,
Which we have.
yeah, I think Canab has it. anyway, it's a tough decision. It's a really tough decision to make. But you put a lot of money into this, and if I were in anybody's shoes over there, I would say, well, let's look at it and see. One of the challenges that we don't have that maintenance fee. We did a different contract, so we're not putting out money every month. And that's helped Blue Mountain Hospital. I don't know whether you can go back and redo your contract, or if there's anything like that you could do to help cut the cost and the expense, but at this point in time, with $1 million in, I don't know about changing, but we did.
It's closer to $1 million.
Yeah.
And we have discussed the possibility of renegotiating.
Yeah,
In
that's,
fact, I
that would
think
be
we're in
my
the process
only,
of
and then
doing
just, like I'm saying, it's a lot of expense, but just be patient, because it will take some time, but in the end, it will benefit you. Yeah, right. Waiting for that to turn on, huh? Yes.
Anybody else have any comments?
I think it's an interesting point of order that if we're discussing other things and you, as chairman, want to recognize somebody for public comment on that specific item,
Yes, that's right. And we've done that in the past, that's true. Just at large, we don't allow public comment within the meeting. We ask for, say, staff members in the public, we might ask specifically Belina a question or something to that effect. For the most part, to keep the meeting running, we don't allow public comment after the time. And really, open meeting law is not required to have any public comment. It's important to have it, and honestly, we usually rarely have any public comment. Fraser comes consistently, but he doesn't even have public comment every time. But we invite you all to our meetings. For the most part, they're pretty stale. It's just a lot of nuts and bolts, but we know how important this healthcare system is to everybody. That's why we're on the board. That's why we give up time to be here. So, okay. Well, we're going to close public comment then if nobody else is back. Okay. We're going to go into financials. Lyman.
Okay, I'd actually like to go to this document here instead of what's in the packet. I think it'll make a little bit more sense. The first page that we have is a trend table. The first column in blue is current 2014, which means January 2014. Budget would be average of a year ago, which would be the center blue column, and then prior would be a year ago. And then we started with 2009, 10, 11, 12, and 13 in the green, indicating what our metrics have been, and then projected 2014 would be a culmination of the first column. So as we go month by month, January, February, the projection will show kind of a trend line. And first bit of data I have would be our admits, 71 for the month. And you can see, starting in 2009, we had 829. We dropped to 711 2013. Patient days were 138 last month. Interesting, if you look in 2009, hit our peak at 1,671 bed days. We dropped to 1,269 bed days. Just a little over 402 bed day drop. Average daily census would be the next line, 4.6 for the month of January. You can see starting in the green, drops from 4.6 to 3.5. Our SNF beds, we had 31 last month. Our budget would be 18. Didn't have any data for 2009, but you can see in 2010 we had 412 and dropped basically 216. Deliveries, 13 last month. You'll see that 2009 we had 92, 2013 we had 92, and we had some years that we dropped down, went back up. Surgeries, 39, and year ago, our budget would be 66, and 2009 we had 487, and we went all the way up to 795 in that range for 2013. ER visits, 153, kind of 1710, we jumped up to 2012 to 1859, it's dropped back down to 1,641. Lab tests, Sherry and I are working on some data there, and I don't think the number I have there would be correct, and so let's move past that one. She's having challenges getting data out of Cerner as well as I am. CT 71, 2009, interesting enough, we had 999. By 2013, we dropped to 696. MRIs 20, 2009, 246. And we actually increased in 2013 to 266. Ultrasounds, 57 last month, 2009, 566, and we were able to have some fairly good years, 671, 795, 711, and 658, which is a little bit of a drop. Our provider clinic, San Juan Clinic, had 778 patient visits, 2009, 5,500, climbed all the way to, in 2012 to 8,700 visits, dropped down to 7,800 in 2013. Blinding Clinic had 467 visits, and it ranged from 4,200 and dropped down to 3,969, so a drop of about 265 or so in a year. Then I have some total operating net revenue. This would be our revenue minus contractuals, $1,089,000. Our expenses, $1,055,000. So we had a net income for the month of January. Then you put in the property tax at 76, gave us $110,000. As you can see, I highlighted some of the red. 2009, 885,000. 2010, 2.3. 2011, 2.6. 2012, 1.8, and 2.1 in 2013. The bottom part, there's some questions about salaries as a percentage of total operating. Salaries, wages, and benefits is $517,000. For the month of January, it's 49%. If you drop over to 2009, it was 52%, 54%, and peaked at 56.9% in 2011, and 55% in 2013. If you'll,
if you don't mind, Lionel.
Yes.
Instead of going past this.
Okay. Which one?
Well, let's look at a number of these. Total operating revenues, which in 2009 were over 10 million, in 2013 were over 10 million.
Mm-hmm.
We have just been told that those revenue figures should be significantly higher, maybe as much as $3 million a year higher. Is that overstated?
Yes.
Okay. Well, then help me out, because you've indicated that there may be $3 million before Cerner that wasn't filled, and I was assuming,
Right,
based on
that
what they
doesn't
said.
mean for a year.
Well, no, they said they couldn't track it for more than a year, so I was assuming that might be a year or two. What would, do you have any estimate of what we would be talking about in terms of additional revenue that was not filled throughout this year? Just, you just be guessing.
If you would guess. Or any idea?
No. Not even an estimate?
Honestly, without full explanation of benefits, I couldn't even estimate. I would say it was a large amount, but I can't put a dollar sign to that.
Well, so how did we come up with this $3 million figure?
This is what we were told when we were sitting in CPSI, that we had not collected previously. No?
No. Remember, we're always about 3.1, 3.2 million gross allowance is usually 2.6. So around there. That's totally.
That would have been prior to CERN.
Yeah,
That's
and
what you,
then-
yeah. And then this is what we're saying since CERN.
Current accounts receivable, I understand that, but I'm still a bit confused by this $3 million figure.
You just, no.
Well, I mean, if, I don't know what the conversation was previously, but if a physician or a patient has received a service in the hospital. If it drops all the way to charges, then it's revenue and goes to accounts receivable. So this would have to be kind of in some, like cyber world. I don't know anything about that.
Shouldn't you know something about that?
Well, I assume that when the x-ray is given, that it's billed, labs are dropped, that it's billed, patient charges, supplies, all of that. So I'm not aware of anything that's out there that wasn't billed.
I think what she was saying was that was what we had in AR prior to Cerner. Like, that's what was still sitting out in AR.
And we
Cerner
put-
number was a whole different, like, starting with Cerner.
Most of that
Yeah.
has been collected.
Most of this has been collected.
I don't know.
Probably
Has it?
collected or contractuals per payer agreements, probably at least 2/9 of that.
So we don't really know what that $3 million
I think we probably won't know what we would be able to say.
Yeah, I have on my balance sheet the CPSI balances, so we know
Okay.
exactly
Oh,
what they
okay.
are. Yeah. So behind my,
Well, I guess
Table.
I have a question on,
yeah.
so if we look at this,
Mm-hmm.
our, you know, our operating revenue that, and I'm down here total net.
Okay.
At 10.4 is our second highest, it's actually our highest year in the last 5 years.
Mm-hmm.
But then our expenses are the highest period ever.
Yes, that's correct.
And then we drop down, we've got, you know, we had higher losses in 210 and 211. I don't know, I guess I'm confused. If we could have controlled our expenses a little better, wouldn't we have been, we would have had a great year, looks to me like. Our surgeries, if we go back up to surgeries, highest ever for
Yeah.
surgeries. Patient days are down, I understand that, and ERs are down, but not
Not significantly.
not significantly. And this is what I'm worried about, is that, you know, we are doing the business, we're just not getting the cash in.
Mhm.
We're just not collecting.
And I've got
And
some
we are
more,
running high on expenses.
I've got some more data on that also that I have some comments. What are behind
This is,
are
by the way, I like
grassroots.
this. This is
Okay,
a great.
and I think that's what Gail had asked for, and so it took a lot of work to get it. We have some graphs that are related to the data on the front page. If you look at the black line, that's related to the data from 2009 through 2012 and 13. And then using the first graph, inpatient admits, the red would be current year, which would be January, the left column. Middle column would be our budget, and then January of 2013 would be the third column. And then, obviously, we're at 71 right now. So that line, and the projected 2014 will move as the year goes along, as the data is input into the field. So everything that is on the front page is now in graphical form also. So I have inpatient admits, inpatient days, deliveries, kind of up and down. Surgeries have had a steady climb on the third page, which is nice to see. ER visits largely up. Ultrasound largely up.
Are these stuff you pulled off the Sage, or is this out of CD,
No,
or out of
just-
Cerner?
No, Cerner.
No?
I'm still waiting for my first report from Cerner.
Okay.
So,
That means
I-
something.
I think that's an excellent question, because we've been asking for 5-year averages for
Mhm.
a very long time.
It just took a long time to get. I apologize for that.
Are these Excel then?
Yes,
How did you come up with the budgets?
just the average of a year ago. Yeah. I mean, we can begin to budget volumes, but I'm just using the averages of a year ago. The MRI is repeated twice, apologize for that. Should have that taken care of by next month.
Yeah, we really, we're not gonna take your public comment. I'm sorry.
I just can ask a question.
Well, I'm sorry, Donna, I'll let you,
So we can, let's skip the graphs in the packet, and we'll just go to the income statement. I've basically given you a condensed version, actually in the board packet, I'm sorry. Let's go to this one. We'll come back to this income statement a little bit later. I'd like to talk about it before my time is up. Have the January 2014 revenues were $1,904,000. Allowances and deductions came in at $817,000. A year ago, I had a month that was similar. The majority were in about the 500,000 range. So it was high and kind of worrisome. So we'll have to see where allowances and deductions go from there. Expenses came in at $1,055,000, which is below budget, but unless we consistently move the revenue line and manage our allowances and deductions, we'll always bat up against the losses. So we had a net income for the month. Doubt if we'll have it for February.
Oh, wait a minute, Mike.
Yes.
Our gross revenue is 1.9 million, which is almost $200,000 over budget. And so what this tells me is, one, we have a problem with contractuals, which we know from the work session that we do. And secondly, we may not be controlling our expenses, although our expenses here are $200,000 less than budget.
It is still a high number, $1,055,000. No question on that.
Yes, it's a high number.
Questions about that? We can drop to our balance sheet on the next page. We have our operating cash of $810,000.
What date is this of?
January, last day of January.
Last day of January.
Yeah, and you'll see it's dropped $528,000 from a year ago, but it's offset by the operating cash of the LBA. We began to fund the LBA so that we can meet our bond requirements with CID. We have $121,000 there. Make our first payment in March for an April due date. Hospital, this would be Cerner, $4,065,000, about $700,000 more than a year ago, which is really, since it was January a year ago, would be CPSI. And then, but I've dropped down and created a new category, hospital CPSI, $169,000, which is the accounts that are remaining in CPSI. Everything else has been collected and allowanced out. Then the physician practice of $147 is a kind of a combination of some Cerner and EMD accounts.
So approximately $400,000, which is, if you add in our LBA revenue, that's fairly close to the $528,000 net change in operating cash and investment. So we've sacrificed our operating cash for accounts receivable because we're not getting our accounts receivable out. Okay. Don, I do have a question. I was telling the board that your accounts receivable are 31 days. Is that accurate?
That's excellent. Okay, dropping down in our other receivables, $558,000, $370,000 of that is DISH and has arrived month of February. Our inventories, prepaid assets are all fairly standard. Down at the bottom, accounts payable, I highlighted the $310,000. It's a positive number. It's nice to be able to drop down. As you know, in November, December, it was climbing quickly. So it's nice to see it drop. So everything was consistent, but you'll notice our total liabilities and fund balance at the bottom are down $844,000 a year ago. So in essence, we're consuming our equity.
The accrued salaries and pension that's negative, is that a year-end?
Yes, it is. It is, yes.
So that's just a journal entry, is what you're saying?
The system generated. Yeah, so it'll go back and forth throughout the year. The next page is our comparative income statement, 2014 versus January of 2013. And you'll see that we have $441,000 more in income, 19 from 1.4 to 1.9. Our allowances were about 170,000 more in January than a year ago. Since there's more revenue, even though allowances are higher, we came in at $1,089,000 with a small amount of grant revenue. Our expenses came through and everything dropped there. But if you'll notice, in the January 2013, last year was offset by down at the very bottom, the CIB, or I put it in the CIB line, but it's the EMR payment from the state of Utah for purchasing and implementing that. So it basically drove our net income a year ago. Okay. The next page, I threw our budget in, but don't worry about that. It's actually was repeated in the other packet that I handed to you. So now, if you, I'd like to go back.
I do have a question about our budget. And
Okay.
I'm sorry for interrupting.
Okay, no.
If we were to adopt this budget, you're asking us to adopt a budget that shows a $1.2, $1.3 million deficit. And under the current circumstances, I have no idea how anybody would expect us to do that. I mean, to me, we have to take a good hard look at our revenue and our expenses, and we're going to have to figure out how we're going to cut that figure.
If you go back to the packet that had the graph and the template on front, the second to last page I'd like to talk about for just a minute. This is actually a document passed to me by the individual that you had met with earlier and talked with. And so he helped on some comparison, wanted to look at some of the things. I liked it enough that I asked him if I could use it, and so I collapsed his data from a comparative standpoint and wanted to look at some of the percentages and how they relate from our hospital to another critical access hospital in the state. And everything is kind of indicated here from 2013, 12, and 11. So it's kind of somewhat redundant to repeat it. But if you'll drop down to salaries and benefits midway through the page, drop over to the 2013, 12, and 11 percentages, and I've highlighted them in red. So you can see what our percentages of salaries and benefits are compared to another Utah critical access hospital. And you can see that we're consistently 2 to 3 and 3 percentage points, sometimes even 4 ahead of another hospital in the state that allowed us to do some comparison.
Sometimes 6%.
And I think that goes back to your point, Steve, that we've got to manage some expenses.
What does that convert to in terms of raw dollars? What is 6% of, okay, 6% of $6 million?
No, 10% would be 691, so probably 450. Just
yeah, $450,000.
It is a lot. You know, small numbers. And you can also see, if you drop just below that, our operating expenses are running at 76, 74, 77%, where they've been able to maintain 69%, which if we were able to be closer to their numbers, we'd probably see a change in net income at the bottom.
On professional fees, Lyman, is that
Yes.
driven by salary also, or is that activity? Where we're 11% and the other hospital's 9 and 7. Is that category driven by doctor production, or is that
No.
driven by salary?
No, and I think the difference there, I'm comfortable with that number, even though I highlight in the sense that the hospital that he is at, the physicians are employed by other practices, and where we purchase radiology services and from Utah Radiology Group and others. So we're a little bit higher, but we'll probably always be a little bit higher. It's just part of who we are.
So if we factor in the differential between salaries and benefits in this other critical access hospital and our excess expenses, we're probably fairly close to $1.5 million.
Yes.
Now, I'm not sure that I'm reading your report correctly, but down here at the bottom it says salaries and benefits. That's broken out.
Yes.
the Utah Critical Access Hospital is at 11%, and we're at 19, 18, and 15.
That's correct.
But that's factored into this $1.5 million figure.
Yes.
That's not in addition to it.
Yes, that's correct. The final.
I have a question.
Oh, yes, yeah.
On the charity care there, we're higher on charity care, is that because we are more obligated to charity care than other critical access hospitals?
No, that is related to the contract that John Hart signed with the Utah Department of Health, that our charity, at that point, we were the only participant in all the rural hospitals in the charity program. Others came behind us, and I'm only aware of one other hospital that has more dish than we do. Everyone else has less dish. So that was a contractual basis why we do, because it's not charity of the hospital or the district, it's that money is reimbursed by the state of Utah through the dish program. But we just report it on that line.
How long has John Hart been gone?
2005, okay.
So we're still working under the contract with the Utah.
How long's that contract?
At least 2 more years. Well, there's been some discussion, the idea under the ARRA Act is that by more people being insured, there'll be less of a need for other safety net programs. And so there is some discussion to be done away with. I think it's highly probability we've got at least 1.5 more years. And I've been expecting.
So you're looking like a 10-year contract?
Yeah. Okay. All right. If you'll notice in the right corner, I've done just a little mathematics. And this is kind of a frustration that I've had with Cerner. And I'll just say Cerner, okay? What I did is I took 2012's gross patient revenue. I subtracted out the clinic. Then I multiplied it by 1.1, which is a 10% increase, which is the cost, which is the charge master increase that we put in on January 1st, 2013. So then with that number, it turned out to be $15,115,000. I added the clinic revenue back in, and then that $17,695,000 number, I then subtracted the $16,638, which is what I got from Cerner in 2013. And if all charges had remained consistent, I would have had $1 million more in revenue, because we went through the charge master. So where did it go? And that's, the answer I'm trying to figure out. And we struggled throughout 2013 if our services were begun, and our pricing of our supplies, our radiology, our lab, everything. We should have been able to gain all of that money, which even if we collected half of that, $500,000, it would have diminished our loss somewhat. And so that's kind of just a sideline. That's all I have. Thank you.
Do we have any more questions for Ryan? What's this last sheet, Ryan?
Oh, I'll talk about that later.
Okay, thank you, Ryan. Old business, number 1, cost savings benefits.
Okay. So I passed out to you in this packet. In that packet. So you guys you asked to, in the last meeting, you wanted to take a look at the benefits. So really what this is, I didn't know if you wanted to just do this as a discussion, but it is what our benefits are right now. We also put in there what we could potentially move to, so from what's current to what we could do if we need to do some benefit costs, and then it would tell you what the state would do on those things also.
Okay.
more of an information sheet for you if we're needing to do something right now, and we need to talk about how we will do that. The other thing that we have talked about is certainly from a cost savings is the idea of the county discount. It's at 25%, which, we did talk to a few other boroughs that said that's pretty high. What they do also, they basically average between 10 and 15. So I didn't know if that's something that you guys wanted to look at or not.
Well,
I think Lyman was gonna start doing we were gonna show how much we were paying for, how much was going out for the county discount.
Well, I think Marina had commented on it tonight, that was just hospital. Do we only discount on hospital or clinic visit also?
Clinic is within 30 days, 25% for self-pay only. Anyone holding insurance in the clinic, because your bills are so much lower. So what we do is offer the self-pay people in the county a 25% discount within 30 days of their first statement. Not their date of service, their statement. That's the difference.
I think the discussion's been that, number one, we haven't promoted our discount very well. We should have done that. Number two, that it's not given like most county hospitals, or not to the extent that we do it. So this is why it falls under cost savings for us. Is because it's under consideration that we would back that off from a 25% discount to a 15 or a 10, or restructure it some way that it was still beneficial to the county residents, because we want to encourage that, but somewhere that we can, because we are in such a financial strait, try to recoup a little bit of what.
I don't know if we've ever done any cost benefit analysis to that. I don't know whether, I mean, I'm assuming that the highest, that the overwhelming percentage of services that we provide are to county residents. So we're taking 25% of our revenue, probably not quite that much, but off the top.
If they pay in a timely manner. And this is a 90-day discount.
No,
Yeah,
I
and then-
appreciate that, but it
So it
seems to me that we
would
are,
be 25% across the board.
we could be discounting ourselves into a very difficult situation.
It's after insurance. It's the residual.
It's the residual, but still, it's a lot of money. Do you, it's Marina? Maureen, I'm sorry. Do you feel that that is an effective tool in collecting those bills?
We have found that even though you say it's not publicized well, a lot of people know about it, because when they call to pay the bill, they ask for it. And we've also educated them that it has to be done within 90 days. They can make 3 months worth of payments, but they have to have that bill paid on the 90th day. And we feel it's helped pay people's bills down. If we carry that out for a whole year, wasn't it worth it to give them a 25% discount compared to carrying that bill for 12 months instead of 3 months? I mean, we gotta look at the long-term effect that bill was paid off in 90 days and off of our books.
Wouldn't it be more effective if they were just paying the bill in 30 days?
Hospitals, clinic does require 30 days, but hospital actually always has done 90, because we're talking, a lot of bills are thousands of dollars.
I'm sorry, a lot of.
They're thousands of dollars. It's large amounts. So.
Well,
I've never really had too many people pay their bill in the hospital within 30 days. If they're owing a couple $1,000s, they usually break that out into a couple of months and they get it paid.
See, and I think one of the things that was haunting us was when Diana and I tried to go through our statements and figure out what was going on, because we recently received some of those older claims, if you will. We tried to figure out the discount. When we called up, we got in the middle of the debate whether it was 20 or 25, and on the gross, was it on the remainder, the residual, the copay? And I think now, I'm guessing that you all are on the same sheet of music.
We knew it was 20% for board members. Previous people did the previous people were giving different amounts to board members. The clinic's always done 20%. We had it in writing. We had the letter. That was our policy. That was our policy.
Board members and employees of the hospital, correct?
Employees of the hospital was 25%. Board members were 20. But you've got two different people working. You have a person working for the hospital. You have a person working for the clinic. The problem we found is too much was given in the hospital. So that's why there was an adjustment. Okay.
And Sonia, do you want to explain how you plan on doing that now? What we talked about the other day when people get their bills.
With the discount, if we continue to have a percentage discount, it's paid within a certain amount of time. On the clinic, well, on the hospital side, they used to put stickers on there that said, take 25% off of this balance and paid within 90 days. On the clinic side, I've always had a sticker on there that I put pay only, and I write in the amount if paid within 30 days. So I give them the amount instead of them giving me an amount. And to me, I find it to be more effective because if you tell somebody, you know, if your bill's $500, but if you pay me $400 now, we'll call it good. Whereas opposed to them looking at it and going, 25%, you know, they don't see the actual number. So if we do continue to go on with a discount, that is my plan on the hospital side when I send out statements, is to have the stickers say pay only and give them an amount if paid within whatever days we decide. So then the patient is aware of what the amount is that they have to pay.
I propose that with all the billing that we're catching up with, that, and we're all on the same sheet of music now, that we hold off on this and see how it runs out in 2 or 3 months and look at it.
Is that a motion?
Yeah. Well, I'm motioning to table.
Okay. Well, I just want to make sure this, you're just talking discounts.
On the,
County.
yeah, so if you, are you gonna make a motion then, or just clarify it?
Yeah, I just motioned to table. Because 3 months. See how it runs out, see how this billing, everything getting billed works, and the billing office changes. Let's watch it.
One thing.
Well, do we have a second for that motion?
If there's no second.
Can we discuss?
Yeah, let's have a second.
Second.
Okay, motion by Guy, or Bird, and second by Guy, let me repeat it for the, that we table the motion, on the county discount, until we, for 3 months, and then look at it again. Sorry, Guy, go ahead.
No, that's okay, I'm sorry, my mind was going fast.
But
This, along with that, I look at, if we're gonna make data-driven decisions, Steve said it, I don't know what effect this all has. You know, how much we're talking about, what benefit it is. But we ought to make this decision. I would like to have some data to know how effective it can be or should be. And so I think we're just shooting in the air without really understanding what the effect is. And maybe somebody knows, I don't.
Well, that's my concern, Guy, is we take a look at 3 months, and we basically put it on the back burner and let it simmer. And in 3 months, we reopen it. I would certainly appreciate some cost-benefit analysis on a number of these things. And also, I don't know, we're talking about whether we can cut benefits. I guess we better talk to our lawyer and see what we have to do relative to our plan, so that we don't run afoul of our plan restrictions.
That's a major decision.
Well, and an intangible that we have to deal with probably can be measured as public relations.
Absolutely. That has to become part of it, but without knowing the impact and really what it means, how do you make that decision? I agree. Anyway, that would be my concern.
Well, I don't know, Maureen, do you actually have any sense, and I realize it's just anecdotal evidence, but do you have any sense of how many people are paying their bill within 90 days as a result of this discount? Or is it simply that they're paying their bill that they might otherwise, paying the bill that they might otherwise pay within 90 days?
I would say, I'm sorry, I know you asked Maureen, but I've been handling hospital. I would say out of 10 calls, I have maybe 7 who call and say, okay, what do I gotta do to get this discount? And I've mentioned no discount. This is something they know is out there, and they wanna know what they can do to get it. So I would definitely say 7 out of 10 phone calls that I get, people want to know about this discount and what they can do to get it.
Well, then I guess the question that I have is, can we afford to offer a 25% discount to county residents? I mean, in a way, it's sort of redistributing tax payments. It's sort of a medical subsidy for some
The
people.
other question of that too is that these are people who are having insurance. We already do a contractual adjustment for their insurance company, and then they're getting 25% off of the balance they owe, on top of the fact that we've already written off what the insurance company told us we had to. And every insurance company is different. Blue Shield is drastically different than PEHP. So it all depends on what they hold for insurance on top of that. But they do have a desire to pay it because it's less money that they owe. And anyone who does budgeting knows that if I can save 25%, I'm going to save that. That's how people look at that.
Well, I realize that, but I also realize that if I have a bill, yes, I'd like to get that 25% discount, but I'm going to pay it anyway because it's something that I owe. And I also understand from a business perspective that while I may very well be interested in offering all of my customers a very serious discount, I may be discounting myself out of business, and that's my concern here, is that I don't know that we can actually afford to offer people a 25% discount. And I asked Donna whether Blue Mountain Hospital and UNHS offers such a discount, and you said no.
And I don't believe Moab does.
Moab used to offer 30%, but they discontinued it.
But the average of what you told us for the last 3 months would be $7,000
A month.
an average. That's only $84,000 a year, which is 1/10 of our taxes. And I'm not downplaying that. I'm saying that it doesn't really erase the tax.
Well, going back to your motion, to table it, rather than table it, can we maybe gather the information to maybe get some data and some dollar figures? What happened the next 3 months with these discounts?
You have a motion in a second.
We have a
You're going to
motion
have to
on the table.
withdraw it,
We can withdraw it
Or maybe that's, I don't know, if you table this, please put it aside and I'll look at it, or maybe table it and get more information to make that decision is what I'm asking. To get that data.
Do you want
That's
monthly
the-
information for the next 3 months, so that you
Yeah.
can see where it's going?
Is a dollar, the actual dollar amounts of, in the clinics and the hospital both, you'll have those dollar amounts of those figures.
I'd also like to have a cost benefit analysis. There's one thing, the 30 days or 90 days. How effective is that? But the difference is, are we charging interest on past balance?
No.
Well, I mean, it seems instructive.
So we don't charge interest on any past balance.
Seems instructive to me that the other health care facilities in the region are not offering this. And that doesn't necessarily make it right, but it certainly would cause me to take a long, hard look at it. And I think that the problem with the cost-benefit analysis is I don't know how, certainly in the short term, how we do that. And most of it's just going to be anecdotal. Now, if I call you and say, I can offer you a 25% discount if you get paid in 90 days, will you pay it?
Right.
Or if I don't offer you the discount, will you?
Well,
still pay in 90
I
days?
think what you do is you look at a scenario. If somebody does, what it means. If you don't, if you're charging interest, if you're doing it, so you compare the case, not, you look at what the outcomes are of our decision. And
Well, the problem with that, guy, is you're gonna have to bifurcate this, so you may get a discount and I may not, and that's probably not gonna work.
No,
very well.
no, that's not what I'm saying. We give 25% discount. What does that mean? What's the outcome if 30%, 40% of the people pay? What does that mean? It's just a matter. If we don't have that, I know there's a lot of supposing, but
No, I mean, to me, the only way that you're going to be able to address that issue is if you have at least 12 months of experience with and without a discount.
that's true, but we have other hospitals that might share some information.
Well, we have other hospitals who may share some information on why they either no longer do it.
They're not doing it or doing it. So I mean, you look at cases, and so that's all I'm saying is I know you could do that, but we ought to have more information.
Maureen, what does that get written off into?
There's a prompt pay discount. It's called a prompt pay discount adjustment.
Is there any way to see that figure every month?
Yeah, that's the report that we ran. Right here, she has it broken down by every patient, every month. Cerner gives her a total every month.
That's what she thinks.
And it's hospital
But
med.
have we kept that data for previous years? Can you extract that data for prior years?
On the clinic side, we can. On the hospital, we're not quite sure because it's an hour versus.
We could go back and Cerner from January on and give it to you. She just ran the past 3 months,
No.
Debbie did, but we could go back all the way from when, say, April on and Cerner.
I'd like to see that history and then like to somehow have Lyman include that figure every month in our
Oh,
report.
right, that's why Debbie thought we were going to see that every month, so
Yeah.
that's why we were bringing it to you today.
What about your motion, Bert? Do you wanna call and vote on that, or should we?
Well, I'm not sure whether we need to say that, but we need to say something, we want to get this down, that part of the motion.
That's the intent. Is to,
Okay, I'll ask you to restate the motion.
Or you can do a friendly.
I'll withdraw my motion. I will let Gail do.
Well, I'll make the motion that we go 3 months and get the data showing us on clinic and hospital, the prompt pay discount, dollar figures.
Historical and running.
And if we can go back as far, as far back as a year if we can. Can we go back a year?
And will you include in that motion that we contact more and get their experience from?
And we'll ask Laura to contact more and, see, I know more I've used to offer the 30% discount if you pay, even if you weren't a county resident.
I'll second.
you pay.
Thank you. Motion by Gail to, go back 3 months or as far as we can, Lyman, and pull out that prompt pay discount number.
I'll see what I can do.
And then, contact Moab and see if they offer, it would, I
You
wonder
know
if
what,
court,
the only one you want to know? Yeah. I thought you ended on that. But they have Cerner, but they're not.
Oh, yeah. Texting somebody.
But are you wanting it just because they're on Cerner?
No, we want
Okay,
just
that's what I'm saying,
for
I can
the
give you,
county
okay,
part of it.
right.
Okay. Any further discussion on that? All those in favor? Any opposed? Motion passes. Now, the rest of this, this is informational on the benefit package. We're not suggesting we change benefits right now, we cut benefits. I think as a board, we've talked about what do we do, what if we get in a situation that it's scale back on benefits or have layoffs, or scale back on benefits or have to have furloughs. So we asked Laurie to get us some information on what our benefits cost, what's some comparisons to some other hospitals that we gathered, and then we need to look at it, and we'll probably visit it sometime in the future. And that's, so I would just encourage board members, make sure documentaries, and then if we have questions, about,
May I suggest that we have a work meeting?
well, and see, there's a benefit committee within the hospital also. I mean, I think we could have a work meeting to look at it, Steve.
Well, that's what I think there's a lot of.
There's a lot of information there. And then touch on it from there, so. Is there anything else in that section that you talked about, Larry?
I think we talked about in the last meeting the things that we have done in regards to like buyback, and we are not necessarily replacing employees that have left. We have started doing a lot of cross-training of the staff that's there, so that's helped. And then, I think we're maybe going to talk about contracts down the line, and so that's right there.
Well, and it's a recurring theme that I've heard a lot. Starting with the top. But people are saying, that's not something I want to do, but I'll do it for the system. And I really want to mention that and tell everybody thanks. All of our employees.
Okay. Here's what we did.
So do you want a motion that we take this up during the work meeting?
Well, we could, we probably can't set a date. We can try.
Well, we
But
can do a work meeting.
you wanna-
Before that scheduled work meeting. Something we're going to need to address.
How long do you think it would take? An hour? So I see if we met an hour before the next board meeting in Monticello.
And in the meantime, you can contact our lawyer and see what we need to do to ensure that our plan. Okay. I'll make that motion.
Okay, motion by Steve and second by Gail to have a work meeting, an hour before the next regular board meeting, which will be in Monticello, so that would put us at, 5 o'clock, I guess, if we can do that.
And that'll take the place of the in-service?
Yeah, let's do that. Any further discussion on that? All those in favor? Motion passes. 5 o'clock, next board meeting. Okay. Insurance contracts.
Okay.
Update on that?
Yeah, if you'll remember in the December meeting, I asked for board approval for some money to hire a consulting company that would look at Cerner and our charge master. And ended up contacting Divergent, which is a consulting company, visited with them a couple times. And at the same time, another individual began helping us outside our system, looking at our charge master, and ended up doing some comparison for us. We had an increase in our rates during that time period. Cerner came on site, did their review, and I now have a call with Divergent on March 13th. I've kind of been waiting to see if there's any pushback from our insurance companies on the increase that we place through our system, and see how they're paying the claims that we have put through the system. So I'd like to delay it just a little bit longer and see if our contractual rate increases. Are we basically, are we raising our rates in the appropriate places that would actually bring us net income? So I'd like to wait.
Is that, maybe I'm confused, is that what we were talking about on this item?
It is.
I thought we were talking about negotiating with United.
Big United.
Yeah, we're waiting to see if they pay the claims. You know,
Okay.
they've always had a blended rate, which I don't prefer at all. I'd like to see how they respond to the recent claims that are now going through the system.
That's just on United?
All of them.
All of them.
We'd like to see how everyone responds.
Is that one? Okay. So Divergent.
It's a consulting company.
That specifically looks at the rate.
Cerner and charge master.
So it looks at our
issues.
Cerner and charge
Yeah.
master. Do you have any idea what that's gonna cost to have?
No, and I want to see actually if the Cerner review actually helps us clean our processes up. It might actually do away with the need for a divergent as far as a Cerner consultant. And this other individual has helped us quite a bit on our charge master, so it's mitigated the issues quite a bit.
Okay. Does anybody have anything else on that one? Should we just keep this as a, we won't take action?
Okay.
I don't really think, we'll just keep this as a recurring.
I don't know if we should have it for next month, because the Cerner part, we have the report, but I don't know if it's all been implemented. I don't know the process there. It might be at the beginning, might be at the middle. I'm not sure where it's at, because I know Debbie's been actively managing it.
So when do you want?
So if Debbie hasn't started the process, I'd like to go to 2 months. If it's well underway, then we should be able to finish that part and then begin to see some of the successes roll through the system.
So April maybe?
Well, let's just keep it on if we need to.
Okay.
Okay.
So we'll just, very
We'll
good.
just roll it over next month if we need to.
Okay. CPSI account write-offs.
Okay. They're all on the last week of December. They're all in place. They're indicated on the balance sheet, and I broke that out so you can see them.
How old are a lot of those? Are they past being able to collect?
Some are within a year, some are over a year.
What about CPSI? We've kind of gone back and forth on the sunset date. Where are we now on that?
I think we can use the system as long as you'd like. I don't think they'll upgrade us. If there was a report we needed, they wouldn't support us. But we do own the server, we own the software. We just don't have a support arrangement in place.
Because of what they said about not being able to get the whole EMR? They
No,
won't.
we just chose not to pay the monthly fee anymore. Trying some cost savings. Same with any other system. We looked at all of them from Crane, where we decided what could we cut out that we're not actively using. So we can use our software. They just won't support it. Give us the help.
Can our IT staff, can our IT staff take care of a lot of what you need anyway?
I think so. I mean, they have a pretty good history with CPSI. I think they feel comfortable with it. A little bit more than maybe Cerner. They're not actively involved in Cerner. Cerner runs Cerner.
I have a question on that. I have it first. Diagnostics, seems like there is. So we owe CPSI $7,084 past months, including an invoice on January 7th.
Did you guys all receive that? Did you send that email to everyone on the aged account balance for our accounts payable?
So
Did you see that?
is that something we're gonna pay and that's the last one?
Should be. Once we pay that, we'll be done. We still have a little bit of Craneware out there too.
9,800,
Yeah.
9,300,
Is that something you want to start seeing? Is that something we want to start seeing, or is it just something periodically we want to look at? It's kind of interesting.
It is. It's probably a little longer than I'd like to see it, but I don't know if they can produce one that's a little more summarized. But it's good to see the days out on some of these.
We're pretty current on most things.
Yeah.
I think we're maybe the most 60 days out on payable right now. Most everything's 30 or less, I think.
Are we in trouble there?
No.
Not even with West.
Not even, no.
Okay. Well, we may ask for that
Okay.
occasionally. Lyman and I
Okay.
echo got that for us, so.
Very good. Sage has good reports.
Right.
Okay.
And she knew that that was a long report, but she said there's no way that she can condense that down. And she tried to,
Yeah.
and Sage wouldn't do that, so.
Well, it looked like to me that, well, I didn't go through it, so I guess I can't comment, but the Cerner was pretty high. About 50 some, 56%. Payable right now.
There is one thing missing though. one page on the big balance that you check it.
Oh, okay, I think because when I talked to her about that, the confusion is if she gives that to you by this board meeting, it's not the current that you, so she said if you want it at the beginning of the month, just understand, by the time you get it, that whole thing can change. This is on.
3 to 4 weeks still.
Right. Right. Well, you wanted that bank statement.
Oh, on the bank statement.
Right.
That's what we're talking about.
Bank statement, first page of the summary.
Oh.
And then Echo was gonna email you because, remember we talked about that there's several accounts and she didn't know which ones you wanted, so I said just email her and that's. So, I said you definitely wanted the big one.
Fill everybody in. Burton asked to see the bank statement, and then how many bank statements do we have? 15 or?
How, no, I don't think that's six or seven, yeah.
Well, and that's, yeah, and that, to follow up with Laura's question, as I asked for the summary page on the big one, and then a list, just a summary list on the other account. So I can see what's going on with the cash.
I think that's a good thing to have, Lyman, maybe.
Doug says that's
It's,
something they do with the city
Okay.
every month. Well,
Usually have a number, but it's nice to see the bank statements go along with that. Okay, anything else in that CPS right up? Let's go to CEO search. Really, we have not actively started a CEO search at this point. There was something put out by Greg Rosenwald at the Rural Hospital Association coordinator. And I don't know if he just sent an email out or if he sent, what did he do? But I got a couple calls on it from people in the county to say, are you guys actively, now have you put out an active search for CEO? And I said, not that I know of yet, so I don't know what happened there.
I think that he did do it through the Rural Hospital
So
Association.
did he like post it on a?
No, I think he just let them know, and so
Just
they've
word of
gotten
mouth.
responses back.
Okay. So, what we talked to you guys last time about was Randall Prost. Do you remember that? He is somebody suggested by Greg Rosenwald with Rule 9 that's available to help us in the interim. He's done this kind of work before. He's been in the senior position in several different hospitals. We're going to meet with him Tuesday and see what.
Oh, he gets it Tuesday.
Oh, okay. I thought we were having it on Tuesday lunch.
We'll get it Tuesday night,
Wednesday lunch.
well, Wednesdays with UNHS.
Okay. Okay. When are we gonna meet? Are we gonna meet with him? Okay. Well, I guess we gotta talk about that. I guess the executive committee was gonna meet with Randall. He's not available to be full-time, and he's not looking for a full-time position. What Greg has said is that he has helped other small hospitals through this transitional period, and he's been very good at it. He's got a lot of experience. He's been the CEO his whole career. He's excellent, and he likes that kind of work. This transition, kind of difficult work. So he's going to help lighten the load on Laurie, help us get some perspectives. I think we're going to have him work on a couple key issues for us when he gets here. And one of those is to help us search for a new CEO. So that's kind of where we're going with that. Along that line, I guess, do you want to talk about the funding we're looking for that, or the?
Sure.
We're not sure about, well, go ahead, Laurie.
Okay, so when Greg approached us with Randall, he said that there's the Flex program that will pay for this, which is pretty much a grant that rural hospitals can get through the Department of Health. Don Wood had called me and said that he did get us a grant to help with this, but he also said, because the other recommendation that has taken place and will take place in the next 2 weeks is there's a financial group coming from Intermountain to do an in-depth financial study of the facility. You know, the person who was working with Lyman definitely did not. And so this one is to bring in an in-depth group, and they are doing it for free. They will be here for probably a week, and then they will come back with their recommendations. So the money that we're getting from the Department of Health is not a lot of money, but one of the other recommendations that had come was that we change our auditing firm to one that has more critical access hospital and rural health clinic knowledge. And so basically they're telling us that we can use this money either for Randall, we could use it for this new firm if we want to do that. And it was recommended that what we may want to say to this firm, because they're an excellent firm at what they do, and we may want to ask them, do we want to use them for some consulting ideas like our charge master, because they do a great charge master. And he said, so you could use it towards that. He said, really, it's up to you which way you want to spend this money. We'll just send them a report on how we did spend it. So I think that's something we'd want to talk about, get Lyman's perspective on it too, and see whether it's worth us just paying Randall ourselves and using that money towards cost report or the other firm.
Is that Edie Bailey?
I think.
Yeah, I bet.
Right, but they said there's a person, they said you'll definitely want to use the Fargo person to come down, and he gave me another name to utilize after we find out what their cost would be, to see how they would help out to make it work better cost.
So I guess basically we're gonna ask Randall, we haven't set up any kind of payment for him, we're not sure what he's looking for that way.
I don't think it's very much.
I don't think he's.
And how long will he be here? That's up to us.
He's only available 1 day a week
So
to
come down
He has a
1 day a
full-time
week.
job
Right.
right now.
Okay, and
Wasatch. What's
No.
his-
We-
no,
Heber.
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 Mhm.
Speaking of.
It is, right. So, I mean, to cover his expenses and that kind of thing, one thing, but I don't know what a daily rate would be, or what we can work out that way. And I think we have to set some expectations for him on what we expect from him and what he expects from us, so. But that's where we're moving on the CEO search. He's gonna help us with that, down the road.
I will tell you too, I did have a long conversation with John Hart.
You did talk to
see if
John.
he would be willing to come back. He asked, why didn't he call 2 months ago? Because he was available 2 months ago. But he's in Kansas City and he's taken on a permanent CEO job, so he appreciated the offer, but he was already.
We had heard John was maybe not working.
Right.
And so we thought, well, he might be a candidate for interim since he knows our system.
Well, and I'd like to point out, it's kind of hard to attract good help when you're facing such financial woes. And we have felt like we needed to put out those fires first. And as far as I'm concerned, and I think the rest of the board, I think Laurie's done a great job, and Debbie and Maureen, Sonia, the whole building crew, the lab. Everybody's just done a great job. We're getting on top of those fires, and it's going to be easier to attract quality applicants for the CEO position.
Okay. Do we still have number 2 on there? I think we had this in my little. Okay. So we're on Cerner billing proposal. I had another one. Cerner billing proposal, I think.
Okay, that's the one, we talked about it at the last board meeting where we talked about having Cerner do the past billing.
Yeah.
And, you know, they had given us a quote of what it would be. We were going to go with that, but then we found out that for them to do that, they were not going to tap in remotely, so we would have to shut down our billing system during the day for them to be able to do these past accounts. So we said, no way, we just can't do that. In the meantime, Maureen and Sonia had said they felt like they could get these past ones going. Go ahead, Maureen.
To add to that too, Cerner was gonna send us all the corrections to do.
Right.
Oh.
So they could bill it. So in other words,
We're
we
doing
had to
all the
do
work
everything,
anyway.
and they were charging us $11 per claim.
Mhm.
We could get 40 claims done in an hour. They're charging us $11 per claim.
They're supposed to
It was six.
No, they traced it.
No, then they
Oh, I thought, did they come back down? Well, even $6 per claim.
Yeah.
We could get that done in 1 hour between the two of us, but we had to do all the corrections for them to, they were just overseeing it and then telling us what to do. So it still was going to involve us a lot.
So we've opted to not go that route, and unless these guys really get in the bind, there's still an option if we want to, but we just didn't feel that was worth it.
Well, and I know, noted in the minutes, it was authorization to spend up to that much
Yeah.
money on those. It wasn't a direct.
Yeah. Okay, that's pretty much that whole item, correct? Okay, that's our new business, and we'll go into administrative report.
Okay, so we talked about Randall, so I'm not gonna talk anymore about him. Let me tell you where we're at on physician recruitment. We do have at least 5 companies, a couple that are permanent placement, a couple that are, or a few that are locum placement, who we've gotten in touch with, told them what our situation was, and so they are actively looking for doctors for us right now. The locum companies have doctors ready to come on board, and so they'll be ready to be in place come May when Dr. Ray and Dr. Peterson exit. They're ready for them right now, but we told them we don't need them right now, so.
Would they do a year contract, or they day?
Some of the companies will do a year, some will do 3 months, some will do 6 months, it just depends on what it is that you want. So, and then, yes, Steve, I got that one too, from him. So, I have a call back into him, so he'll probably call tomorrow. Yeah. So we have that opportunity to do that. We have, Dr. Peterson has stated that he would like to still do locums in the ER, like 1 weekend a month. Dr. Ray mentioned today that he would like to help out also. Dr. Allen would like to do some coverage, and Dr. Chappell would like to do some coverage. So we definitely have our weekends covered. We can have actually some weeknights with a couple of them, but I think what we're gonna end up doing is with the companies, while we're looking at permanent placements, will be the ones to cover clinic and emergency room, and we have OB experience also. We also have a meeting set up with Blue Mountain and UNHS this coming week to see what we can do position-wise, how we can help each other out that way too, if that's even a possibility. So we're really kind of holding off on having the company send us the CDs until we hear what we can maybe do with the Mountain and UNHS. So once we know what's going on there, if there is a possibility of anything, then we'll go ahead and tell them to start sending the CVs to us, and we can actually interview the people also and decide who we want to have. So we've got that going on, the physician recruitment. Also,
I'm sorry, where's Chapel from?
He's from Richfield. We've had him before.
He's
really-
credentialed, right?
Yeah. The other thing that goes along with that, we have the Provo OBGYN group who called Dr. Warner. This is a group that has 25 doctors in it of OB and GYN. So Dr. Warner, who is one of the GYN surgeons but also does OB, is willing to have him and one of the other doctors rotate coming down once a month to do GYN surgery. And so they'll come for 3 days a month, and they will see patients, they'll do the surgeries, they'll stay for the 3 days, scheduling patients for the next month, and rounding on the ones they've done surgery on. So they're looking at a Thursday, Friday, Saturday situation. And then they'll go back up north. The other thing is they would like to have the doctors, if there's high-risk OB that they're concerned about, to refer to them while they're here if they want them to see those patients. The other thing, they will be here probably the week of the 13th, and we've asked UNHS and Blue Mountain if they would like to come and meet with them too, to see if they want to be a part of that also. So they'll be coming down with their administrator to check out the clinic, to check out the hospital surgery, and then we'll be able to get things
Will they
rolling
be
there.
touring also, or?
We'll find out.
Okay.
Yeah, so we'll just see how that's going to work out.
What about internists, or are you looking at,
We've asked the recruiting companies to look for 2 family practicing internists. The other thing, again, on the week of the 13th, we will have Grand Junction coming down. It's Craig Marsh with the physician relations team, who want to come and talk to us about specialists and bringing specialists to the area. We've again invited UNHS and Blue Mountain to that, and they will be coming to that meeting also. So it's going to be a lunch meeting, so any of you guys that want to come to it. And we're looking at definitely neurology. Yes.
March 13th?
Yes. Neurology, urology. We have cardiology already by the University of Utah. What is it? Oncology. Thank you. Thanks, Belina. And oncology. Yes. So they want to come down and meet with both groups and see what they can do to help us out in this area.
What day is March 13th?
Wednesday, Thursday, Friday. Who can confirm? Thursday. Yeah. And they'll be here for like 2 hours, is what it'll be. Okay.
We don't have a meeting, it's not 2 hours.
Sorry. We are having a meeting March 5th with Huron Landing, with UNHS and Blue Mountain and San Juan. So it will be Dr. Jones, Mike Jensen, Jimmy Johnson, Jeremy Lyman, and maybe a board member. I think someone else.
From UNHS or
You
Blue
know,
Mountain?
you know? It's somebody.
Did you
And
want a board member there?
that's up to you guys. I was wondering if Steve maybe wanted to be there. It's a lunch at noon. 12:30.
Yes, I have to take lunch to the Don's, but I should be back by then.
Okay, well, if you can. And then we have, yeah, I mean, so this is kind of, and then we've got Dr. Jensen going, and myself, and Debbie Christensen, and Lyman, Jepson, sorry, going from our side, and if a board member wants to come too, and this is.
That's March 5th?
Mhm.
I've got a board meeting in Moab.
Well,
Racing board.
Oh.
I'd say, Steve, if you can make it, if you have a problem, you don't pinch
I
it, guy.
think I can.
Yeah, I think
That's a
I can.
Wednesday.
Mhm. It's next Wednesday.
She's coming Wednesday, isn't it?
Yeah. And it's at the,
And you said 12:30?
Homestead. Homestead restaurant. Homestead? Homestead, okay, yeah, Homestead restaurant.
Four Corners in.
Oh,
By
In
Zions.
between Zions
No,
and-
no, it's in Blanding.
Yeah, it's
Sherry
between
Zions.
Zions
Oh,
Bank.
By
It's
okay.
between
Zions.
Zions and the.
Next door to Zions Bank.
Yeah.
Steve.
So we're,
Granger.
you're going over?
Nine-thirty.
We may talk.
so we're pretty excited about that meeting. This is like the meet and greet and see how we can collaborate, what kind of services we can share, how we can help them out. You know, right now they're looking for some surgery techs that we could probably help them out with. We've talked about maybe sharing their surgeon along with Dr. Vasquez being there also, so that we can cover the things that Dr. Pace was doing. So we feel like we're pretty excited about that meeting. We think that's gonna be really
That's
good.
purely those 3 entities, nobody's coming in for that one, that's just.
Well, the Randall Probes, he's
Oh,
gonna
okay.
come to it.
Randall will be there this coming Wednesday.
So he's coming to it. And Greg Rosenball had sent an email saying that Greg Bell, who's over the Utah Hospital Association, wanted Greg Rosenbaum to be there because he thought it would be a good thing. And he said, I wasn't gonna be there, but maybe by phone. And I said, you know, this is the meet and greet. I think we're planning on having a monthly meeting. So maybe let us get through this one and then, you know, we can invite them to come to one of the other ones. And we did put in for the RECEP grant, which it did get accepted. Our grant writer felt like, she felt pretty positive about it, so we'll keep our fingers crossed to see if that becomes available to us.
Explain that again about
Okay,
the
the-
minors.
Yeah, it's, you know, for the minors' lung cancer type one.
What do they
So
fund generally?
it's for screenings
Okay.
and education.
So it would be money we're applying to do new screenings, or it's money that we?
It's a grant that they'll give so much money for us to go ahead and then if you find things, you know, you can go ahead and still get paid for those.
Do we advertise that one?
Well, we don't know. We don't know if we
I
have.
mean.
Yeah, we will.
We got it in the past, then we put out to.
We haven't gotten it.
Oh, we have?
No, so we're hoping.
That was
we get
the,
this.
that was,
You're talking the
Victims of
DMT,
Military.
yeah.
That's
That one, the Department of Health and federal government can stop that funding.
So we never got research, how many times we put it?
3.
Radiation exposure screening and education program.
I'd like to just let you know that we have had that grant now for 4 years, so if there's any way that we can have with the applications that are in, or coordinate and make sure that we can get.
You find if you get it the first year, do you keep getting it?
You have to
Okay,
get
they
it.
might get it.
Well, if we can get it the first year, maybe.
Yeah, we're willing to accept it, you're qualifying in a different category than we are.
Okay.
So if you're willing to accept that, then that's separate from us, but we can coordinate, make sure. It's the reporting that becomes the issue, and that's where we might be able to wise.
Okay.
And since Rodney's here, I'm just gonna kind of put him on the spot because he's gonna hate me for this. I'm gonna do it anyway. No, Rodney. So I want you to tell him what you did. This is that letter that you have in your packet here.
We just we had a EKG machine we've had since about 2007, I think, 6 or 7. It's been under service contract ever since we had it. It ran out of end of life usage here last year. They notified us. Sent us a letter that they'd be willing to upgrade our machine, give us a sizable discount on a new machine. But we decided not to go with it at the time. In January, it kind of went down. They didn't pay us repairable. The company that the machine came from Quint Science originally. Matara is another company that bought them out. And Matara wanted to get their machine in. So they were going to give us a discount, bring one down. We decided not to do it because we didn't have the money to do it. And our machine quit in January, so I called them up. And they didn't have the parts to fix it and wanted us to buy a new machine as soon as possible. So they were from $7,000 to $10,000. I got talking with one of the guys and told him I thought since the machine was still under contract until March, that it was up to them to keep us with the machine in operation. That's kind of the way our contract is. After several phone calls, they finally agreed and said they would replace ours with a brand new machine. I actually got the machine 2 days ago. Got the part and stuff that goes with it today. So hopefully by the end of next week, we might have enough for it. Somebody's got to come in and trade us, but save us about $7,000. And it should have a 2-year warranty on it. So.
Rodney's over quick with me.
Thanks, Much other stuff can be.
I know.
We just got lucky on this one.
Thank you.
It broke down at the right time.
Okay, and then the last thing that I have right now, and I'm putting another person on this side, is our superhero Belina. In case you guys didn't know, we do have a fundraiser that the EMS is doing it to help her with her treatments. And so here's the flyer on it. It's a 5K that's on March 22nd. So we'd love everybody to be out there to help support Galena. And that's what.
Okay. Well, where are we at? Next,
We had a big change this morning on election, third election in many months for chief of medical staff, which was probably largely brought about by the board, which we did over and I won't go over that point. They elected me again to kind of trust for final, and I resigned, and Dr. Jensen was elected chief of medical staff. I read this morning some of the duties of the chief of medical staff, and one of them I think is pertinent to some of the voices that you've heard today. It says the chief is to represent the views, policies, needs, and grievances of the medical staff and government board. And I think there was some thought here that I should do that. As I have done now, I think there's been some getting I've been doing this through the years, and I have heard a lot from the medical staff. I hope that in the future you guys will be sensitive to that role that the chief has. Because he's going to hear things, he's going to be told things that in many cases people were afraid to say and think that were thing they wanted to remain anonymous. And it's one of those things that listen to, I think some of the flyers that we put out before they're started. So I just want to encourage you to allow whoever becomes chief and remains chief or is chief in the future to have access to you for those kinds of things. I think we're all a little concerned about, the doctors leaving. We love our patients. I'm concerned. I need to speak for myself that way. I'm concerned about my colleagues. I did offer in my letter of resignation to come back and help. I've not heard anything back from him, but I talked to Lori a little bit about that hearing staff being this morning. Still not quite clear on where I stand with that, but I have offered to come back and help. I'm going to need an answer on that pretty soon as to what you want to do. I don't know if you guys have thought about that or talked about that.
we haven't had a chance to talk about it.
You offered and then Dr. Peterson's offered too. We want to make sure that you guys can function if it's possible. Continue to function in both three places here coming up.
Is that part of our discussion on closed session?
Well, position contracts. Yeah.
Anything else? Just other minor changes. I think there's something else that you could like to stop.
Well, I want to thank you, Dr. Ray, for all your service, and we hate to lose him. Sincerely.
We're certainly signing that goal.
And thank you for the time you put on board. It's been tough stuff. Well, okay. We're on to, we have Richard Ward, PT, Alexander Stahl.
Is it the recommendation of medical staff to be re-credentialed?
One of these is a gentleman that comes down with a cardiology group. So they're probably ready to pretty well. We don't know how well it works. And of course, you guys should know Richard. He's fantastic.
Does he actually come to our facilities? time, so I'll make a motion to be.
Motion by Steve, second by Guy to re-credential Rich Ward, Alexander. Any further discussion on that? All those in favor? Passes. This time we're gonna go into closed session if I get a motion.
I'll make the motion.
We'll talk about personnel issues, possible litigation, for a second. Motion by Steve, second by Guy, to go into closed session.